case-based discussion, and it was done last month also. And luckily, last month also there was a good number of doctors who joined it, and later on also they reverted that they enjoyed and they learned a lot. Today we have very brilliant speaker with us, Dr. Arvind Gupta sir, and he will be speaking. He will be discussing cases of the young diabetes. And before we move for the scientific session, I will request Dr. K K Pareek sir to say few words of blessings so that all the team gets motivated and boost their morale.
Thank you, dear. Thank you, Prakash. Welcome all dignitaries on the screen, especially our President-elect RSSDI, Dr. Rakesh Sai, a very good human being, a very versatile person, and a great academician. I mean, we need leaders like him. Then only the association can progress. So, friends, another initiative taken by our dynamic president, Dr. Girish Mathur, which is added to so many great initiatives he has taken in the past and which are being continued. I think this is really a best example of dissemination of knowledge, so that even at the last corner, say a physician sitting at the last corner will be benefited, because we know that physical conferences are very good. It gives a motivation, fellowship, and everything. But I still think that the virtual platform CME program are still very important, because you reach to many persons. There is a problem of time, there is a problem of money, there is a problem of... So this is the best thing to disseminate the knowledge to our physicians sitting in the district. So thank you very much, Dr. Girish Mathur. And I congratulate and compliment for this initiative. This is the second part. I also welcome Dr. Prakash Keswani, who is Chairman-elect RSSDI Rajasthan. He is the project director of this. Rather, he is the project director of so many CME programs, certificate courses, and so many things. So thank you, Dr. Dear Prakash. And then I also welcome our speaker, Dr. Arvind Gupta, who is well-known academician all over the country. And his knowledge, nobody can challenge his knowledge about diabetes. So thank you very much for sparing your valuable time, sir.
Thank you.
For panelists, Dr. Sanjiv Maheshwari, Senior Consultant Physician and Vice Dean-elect API, and source of inspiration to many persons. So hard-working a person that one cannot match with his energy. And so thank you, dear. Pradyumn Sharma, we all know, just discussing how dynamic person he is. He is the, probably in Corona time, he was the person who initiated all CME programs on RSSDI and API level. Then Dr. Tak, known endocrinologist of great repute. So he'll also be discussing. He is a panelist. And Dr. Ramchandani, the man behind RSSDI Rajasthan chapter for last so many years, and he's taking this responsibility to a great extent, and is a hard-working person, and is really a pillar, I can say, pillar of strength to our RSSDI. So thank you all, and thank you very much for inviting me. Thank you so much.
Thank you, sir. Thank you very much for your kind words. Dr. Girish Mathur is such a dynamic man that we can see there are so many changes in the working of API as well as the RSSDI Rajasthan. He is not only the API chairman, president, but also the chairman of RSSDI Rajasthan. And he has started so many good things in the RSSDI Rajasthan chapter, including the small places, CMEs, and this case-based discussion, and so many other things. I will request Dr. Girish Mathur sir to say a few words for all of us.
Thank you, Prakash ji. My mentor, Dr. K K Pareek, President ISCM, past President API, past Chairman RSSDI Rajasthan Chapter. Dr. Rakesh Sahai, President-elect RSSDI. Dr. Prakash Keswani ji, Chairman-elect RSSDI Rajasthan Chapter, Project Director of this program and the man behind this program. Dr. G D Ramchandani, our young and dynamic Secretary, Rajasthan Chapter, RSSDI. Our distinguished faculty of this evening, Dr. Arvind Gupta ji, past Chairman, RSSDI Rajasthan Chapter. He is always with us for any academic program. I am grateful to him. Dr. Pradyumn Sharma ji, Dr. Sanjiv Maheshwari, Dr. Sandeep Tak, all our eminent faculties. It's my immense pleasure to welcome our President-elect RSSDI, Dr. Rakesh Sahai. I am grateful to him for accepting my request and sparing his valuable time to join webinar this evening. Thank you so much, Dr. Rakesh. We, RSSDI Rajasthan Chapter, has started two projects this year. One is district CME programs, which will be done physically at smaller districts. In June, we have done two programs. June and July, we have done two programs, one at Sikar and another at Alwar. Another program will be done virtually. There's a case-based discussion directed by Dr. Prakash Keswani. Every month we'll be doing, and this is the second program in the series. Today, Dr. Arvind Gupta and the distinguished faculties, Dr. Sanjiv Maheshwari, Dr. Pradyumn Sharma, and Dr. Sandeep Tak, and will be discussing an interesting case scenario. Are all young diabetics type 1? We often come across this dilemma in our clinical practice. I am sure we will be much wise after today's scientific deliberation. My sincere thanks to all distinguished faculty for joining us and all of you for joining this evening for the webinar. Thank you so much.
Thank you, sir. Thank you very much for your kind words. And whenever we see the face of yourself as well as Dr. Pareek sir, we always get inspired and we always have wish to do something more.
Thank you.
Now, we welcome our President-elect, Dr. Rakesh Sai, a good friend of mine, a endocrinologist of good repute, known all over India, and has remained President Endocrine Society of India also, and previously of the so many other organizations. Luckily, he is with us, and to witness this scientific program, I will request Dr. Rakesh Sai.
Thank you, sir. Thank you. Good evening to one and all. At the outset, I should thank Dr. Girish Mathur for the president of API. He's a very dynamic person, as we have just heard. Made many important changes in the API, and also he is leading the RSSDI Rajasthan chapter. And I'm really honored to be here today in this program. And this is being conducted under the guidance of none other than Dr. K K Pareek, who has been himself a very vibrant and I would say a stalwart in API. He has held many positions in API, and we all are guided by him, and I'm very happy that he is guiding the Rajasthan chapter of RSSDI, and under his guidance these programs are being carried out. I'm very happy that we are having such an interesting academic discussion today, and I should congratulate Dr. Arvind Gupta for taking up this topic, because this is a very relevant topic today, because we are seeing a lot of young type 2 diabetics, and then at the same time we are seeing that the prevalence of type 1 diabetes is also increasing. we are seeing. So there is always a confusion amongst these younger individuals when they present with diabetes. We see, all of us are seeing quite a few of our patients being in the age group of 10 to 30, who are always an enigma. We are trying to understand whether they are type 1 diabetics or whether they are type 2 diabetics, because they have features of all these all these different types of diabetes. Many of them are lean and thin. They have not had ketoacidosis, but they have significantly high insulin requirement. On the other hand, we have the frankly obese, overweight ones with family history of diabetes, where we clearly make out that it is type 2 diabetes. So it is always a challenge. Many times clinical decisions can be taken, but there are challenges, and more than 50% of these patients, we have a great difficulty in deciding which type of diabetes it is. And so I think we are going to have a very interesting discussion today. I also congratulate the panelists. I mean, welcome the panelists who are going to be here today with us: Dr. Sandeep Tak, Dr. Sanjiv Maheshwari, and Dr. Pradyumn Sharma, who have all been very active members of the RSSDI, and also in various organizations like API. Also, they have been very active. And today, I think one of the best parts is that we have an amalgamation of different societies. I mean, we are all part of API, part of RSSDI, and it is ultimately that we are trying to disseminate the knowledge to everyone at the all the physicians across the country, so that overall the final beneficiaries, the patients, who will definitely get better care through by conducting all these programs. So I congratulate the Rajasthan chapter. I'm really honored to be here amongst all of you, and I think this is one of the most vibrant chapters of RSSDI, one of the most vibrant state chapters of RSSDI, conducting so many meetings and so many programs. So I congratulate each one of you, and I'm very happy to be here today. And I would thank you for inviting me to be here.
Thank you, Dr. Saheb, for your kind words. And now we move towards our scientific program. And Dr. As we have already discussed, Dr. Arvind Gupta, who is the senior diabetologist, known diabetologist, good academician across the country, will be presenting good cases of diabetes who are young and have dilemma in the diagnosis of type of diabetes. And for this, we have three very learned panelists: Dr. Pradyumn Sharma, Dr. Sanjiv Maheshwari, and Dr. Sandeep Tak. They will make the session very interesting and lively. And now I will request Dr. Arvind Gupta to please start your deliberation.
Sir, can I share my,
Yours.
Yeah. My slides are visible?
Not yet. Yes, now they are visible.
Yeah. So they are full screen now. Okay.
Yes.
Okay. Thank you, Dr. Prakash Keswani. And at the outset, respected Dr. Pareek Sahab, Dr. Girish Mathur Sahab, Chairman RSSDI Rajasthan Chapter and President API, and Dr. Rakesh Sahab, President-elect RSSDI, and my co-panelists, Dr. Sanjiv Maheshwari, Dr. Pradyumn Sharma Sahab, and Dr. Sandeep Tak, and my dear friends. Today, what we will be discussing a very important topic, like all young diabetics are not type 1. So let us start with the case scenario. These are my disclosures. So dear friends, as Dr. Rakesh said, Dr. Prakash Keswani sahab, and everybody has told just now, that prevalence of diabetes is increasing. Recently, you have seen the ICMR India publication in Lancet that it is more than 1 million population. Around 104 million population already suffering from diabetes in India, and increasing in the epidemic proportions. So challenges are definitely there. And definitely there is a diagnostic dilemma, especially for the young diabetes. And until unless we diagnose properly or the correct diagnosis is there, then the treatment is always on the right track. Dear friends, we need the cooperation and compliance. That is the major issue in management of young diabetes. Of course, complications, they are more common and more severe if they are there. And that's why nowadays it is said that a patient-centered approach should be there. And of course, we have to have the whole family, whole patient, family and peers to take into account, and then the best management of any diabetes patient occurs. Dear friends, I will be talking few cases today, but this is I think the most important and very important case today. This is my real case. This boy, young boy, 22 years male, he came with the, and this is, I'm talking of 2003. 6 September 2003, he came to me with the complaints of all the osmotic symptoms like polydipsia, polyuria, polyphagia, which is very common for just for a 1 week. And he had a fever, also weight loss for around 4 kilograms per month that he is telling to me. He told me at that time. His weight at that time was 75 kilograms. His BMI was, he was overweight. It is 29. His pulse was 86. Blood pressure was 130/80. And when we saw the blood sugars, the fasting sugars were 256. Postprandial sugars were 453. Hemoglobin A1C was 11.3%. Dear friends, he had the urine, ketones in the urine, and seems to be, but the patient was just telling me that he doesn't have that too much of problem. When we go for the different, systemic examination, we did not find any abnormal systemic examination, but lipid profile showed very high. Cholesterol was 225, his triglyceride was 185, creatinine was 0.95, which is normal, and liver enzymes were 48 and 42. Since he was a little overweight, it was okay for liver enzymes. When we inquired about the family history, then his mother was type 2 diabetes, and actually she was also my patient. Hypothyroidism, she had hypothyroidism and hypertension. So she had multiple problems at that time also, and his father was only hypertensive. So family history was strongly positive for that boy. He is 22 years. This was the total when he came to me. Dr. Pradyumn Sharma sir.
Yes, sir.
Sir, now what should be our approach in this patient? I'll tell you just in the next slide what we have done. So what we should do in this case, because urine ketones were positive, he had a fever and weight loss. What we should start in this patient? This type of patients.
But the point is this, we have to investigate, we have to see, because by history and the presentation, it looks like a type 1 diabetes, number one.
Yeah.
Because in type 2 diabetes, you don't get generally urine ketones otherwise.
Right.
But looking at the picture and the loss of the weight and the very rapid, it is a type 1 diabetic, looks like. So we have to go over the C-peptide level to assess the situation and the line management, because that will make us a little more wise enough to go through this, the whole scenario and the approach.
Right.
Yes.
So actually he went to first his family physician. He started glimepiride metformin for 1 month, but actually he came, he was already taking this medicine earlier. But the sugars you have seen, the urine ketones were positive, and the C-peptide was very low at that time, 0.5 millimole per liter. Then he consulted actually endocrinologist, and the endocrinologist started human Lispromix at that time, and Lispromix was actually just started in the market. and he was on 34, around 64 units per day. But simultaneously, because of his overweight, metformin was also given 1 gram twice a day. But in spite of that, the blood sugar was totally uncontrolled. In fact, he was diagnosed Cox's, and he took anti-tubercular treatment for 1 year. And after this started with the human insulin and all this metformin, the blood sugar was 190 by, the fasting was 190 and PP was 220, and his hemoglobin A1C was 10.4. This is when he consulted in the next to us. Now, let us see what this is in 2003. 4 years he continued the human insulin, almost titrating the human insulin by himself. Sometimes he consulted the family physician, and 4 years he was on insulin. But when he came again to me on 2007, his weight was 73, blood sugar was 189, postprandial sugar was 240, and hemoglobin A1C was still very, very high, 11.2. Pulse was little less. At the time it was 55, blood pressure was normal, enzymes were very, very raised. Liver enzymes, 95 by 107. His LDL was 108, but triglyceride rose to 980. Probably either he was not having any dietary restrictions and he was taking everything. He did not have any diet restriction in last 4 years or so. So he came with this. Now we have actually, this patient was continued on human insulin around 60 to 70 units plus metformin. And because his triglyceride was 980, the fenofibrate was started, and also for the liver enzymes, UDCA was started. Dr. Sanjiv Maheshwari, sir, is it right to continue the same treatment, seeing the situation?
Of course, it is right to continue the same treatment, but metformin, why the metformin has been started, I don't know, because when the C-peptide was low, I really don't know whether metformin is working or not, because either when the patient has gone, put up the weight, there are two reasons: whether the earlier diagnosis of type 1 was wrong, or it is because of the higher doses of insulin patient has put on the weight. So we have to revise our diagnosis, and then we have to start the metformin. If it is truly the metformin, then the doses of metformin are relatively less if it's type 2. And looking to the body weight, doses should be increased. And one other thing, when the liver enzymes are raised, metformin should be given with caution. Per se, metformin can also cause a rise in liver enzymes.
Okay. So I think, but that this patient continued with this treatment, and let us see after 1 year, he came, weight was still same, 73 kilograms. His blood sugar was very, very high, 413 fasting and 391 postprandial. Hemoglobin A1C still was very high, 12.2. His triglyceride was, of course, little less. At this time, it was 400. OTPT was almost on the same, 88 by 70. Pulse and blood pressure was normal. So he continued the Lispromix around 80 units and a little more. Continued the metformin, but acarbose was started because his sugars were very high. Now, Dr. Tak.
May I interfere?
Yeah,
May I interfere?
sir. Please.
Sir, me had been in this place. I would have loved to give, because I don't find metformin, anything against metformin. We can continue metformin in such a scenario. But the most important is diet management is very important. Whatever you do, if you're not managing diets, the things go worse. And what we are observing, because he's already overweight.
Very careless boy. He was a very careless boy, and we motivated. And actually, I took little more time for counseling him.
I agree with you. The counseling is very important. No, but I would have been loved to have add pioglitazone, because the point is this: the way the scenario things are, and he must be having a fatty liver with high set TG. And pioglitazone is a very good drug in insulin sensitizing and making the things on a much better side, because it's a fatty liver, things are happening, taking the such a place. So pioglitazone is a very promising molecule in such a scenario.
I think
Because at that time we don't have a
Dr.
DP4 SGLT2.
Yeah, Dr. Pradyumn Sharma sir. I think pioglitazone, but this is my personal thing. I'll ask the other Dr. Tak also regarding this. But I'm not very much comfortable with the pioglitazone in this boy, 22-year-old boy. So Dr. Tak, what do you think?
Yes, sir. Very interesting case. First thing is, we know almost 3 years insulin is not working. First, I think we should be going back to what the real diagnosis is. We should be repeating the C-peptide, particularly 1 hour after next meal, and see
Yes.
what's the response.
Yes. Yes.
Because persistently giving a very high doses of insulin, almost 100 units per day, it's not working. And
Yes.
definitely, we can afford, we should go for the antibodies, GAD65 antibodies on all that. Apart from that,
Right. I think, yeah. Anybody, please mute all others, please. Yeah, Dr. Tak, please.
yes, sir. This point, the underlying metabolic.
K K Sharma sir, your please mute Dr. K K Sharma sir. Yeah.
Yeah, this boy definitely has an underlying insulin resistance as well as the metabolic syndrome. The way SGOT, SGPT are designed, the way triglyceride is very high. All these features suggest this patient has a metabolic syndrome and significant insulin resistance. Diagnosis type 1 or maybe type 2, but he definitely has a significant insulin resistance. So we have to address
So what we should do this in this case?
Optimal doses of metformin, almost 2 gram to 2.5 gram BD would be best.
Already he was on 2 grams of metformin.
As Pradyumn sir suggested, definitely we can try pioglitazone, because sometimes we have seen a very good result of the resistance, particularly.
Okay.
And with OTPT being underlying, is going towards the
Okay,
NASH.
so now, Dr. Tak, this is the 2009. This is after, again after 1 year. This is blood sugar was 306, PP was 323, hemoglobin A1C was still very high, 11.6, cholesterol little less, triglyceride 368, pulse is still low, it is 53, blood pressure 130/80, and he continued the lispromix in the high doses, metformin full doses of 2 grams, and acarbose. Again,
Yeah,
please.
We should be having a, we should thyroid function also persistently low blood pulse
thyroid,
rate.
we have done the thyroid function, they were normal.
Yeah.
Okay, so in April 2010, his weight little bit less, it was 71, but blood sugar fasting 173, PP was 249, and hemoglobin A1C surprisingly was 8. But his cholesterol and triglyceride were still high. So he was continued, stopped the acarbose because of some side effects of the acarbose. GI intolerance was there. So the acarbose was stopped. Only lispromix and metformin was continued in this case. Now, this is now turning point, sir. After 10 years, actually he had some turmoil phase during this 10 years phase, and he was, having some personal family problems. So he actually consulted his family physicians for 10 years. He came to me last year in June 2022. His weight was still 71, blood sugars were still high, 220 fasting, and 315 pp. Hemoglobin A1C was very high. It is again 10.1. Triglyceride was 311. I changed because I thought that let us change the insulin Lispromix, probably, I don't know, as Dr. Tak has suggested that maybe insulin resistance or something. So because the IDEC-S was there, so we wanted to change the insulin. Nothing any particular about that, why I should have started the IDEC-S. So IDEC-S was started, that is Rhizodec, and it was around 24 and 20 units were given. Metformin was there, and I started linagliptin in this case, thinking of that maybe my diagnosis or other diagnosis was not very right. So I thought that let us see the DPP-4 inhibitors. This was in June 22. Then within a month, he came to me again with blood sugars are much better. It was 185 fasting, PP was 243, and hemoglobin A1C. Actually, this 10.1, actually he had the earlier one. So it was repeated by himself. HbA1c, it was 9.8. So the dose of IDEC-S I reduced to a little bit on the, the night dose, and I started the empagliflozin plus metformin and lina. So these three combination I started in this case along with Rhizodec, this IDEC-S 28 and 18. It was right move or it was, empirical thing? Dr. Sanjiv Maheshwari, please.
Sir, I think it was absolutely empirical because we have to revise our diagnosis. Once the C-peptide was low, why we are continuing with the drugs which are not acting on the insulinopenic patient?
Okay.
So looking to the response, so whatever the reason may be, looking to the response of the drugs which we are receiving, we have to revise our diagnosis. We have to get the things, the investigation again.
So I think we will be discussing this point is very, very critical and very sensitive, the C-peptide. Because C-peptide, Dr. Maheshwari, was done very early when the patients were diagnosed for the first time. It was actually a exhaustive time. The patient came with the diabetic ketoacidosis. And at that time, we did the C-peptide. Unfortunately, C-peptide was not repeated later on. This was, I think, one of the mistakes committed. And you are right. We will be discussing this point just a little later. So I think what we have done is Lina, EMPA, and metformin, because actually the SGLT2 inhibitors, there were some trials by Dr. Paresh Dandona from the US, and I knew about those trials in type 1 diabetes, that he started SGLT2 inhibitors in type 1 diabetes also, and he found good results in few patients. Dr. Paresh Dandona, you must be knowing his studies. So that's why the reasons for starting empagliflozin was only that. I thought that the patient is uncontrolled still for last almost 20 years. Why we should not have the trial of empagliflozin? This was the reason. And let us see, this is the February 23. He came with weight loss of around 67 kilograms. His fasting sugar was 148. His PP was 190. HbA1c was still high. It was 9.8, 9.5. I reduced the doses of IDEC-S to around 18 and 12. Lina, Met, and EMPA I continued. And dear friends, within 2 weeks, he came to me again with recurrent hypoglycemia. Not even once, but twice or thrice he got the hypoglycemia. He was feeling vertigo and he was feeling very low. So he consulted me within 2 weeks. His weight was still 3 kilograms low within 2 weeks. It was 64. His blood sugar was 110. PP was 145. So I reduced to, I was actually afraid of how to stop the insulin in this case, because he was taking insulin for last 20 years. IDEC-S, I give only 6 units, and Lina, metformin, EMPA was continuing in this case. Unfortunately, even with 6 units, he was feeling a little hypos later on. Dr. Prakash.
Yes, sir.
What do you think?
Sir, in this case, particularly when we see that glutens have caused a marked change, possibly the C-peptide which was done earlier was
Yes.
in certain catabolic states or was not done properly or has taken some medicines and that has caused suppression of the C-peptide. And of course, as we cannot do get antibodies, so that was not confirmed by that. So one single value of C-peptide must have come low at that time. And this patient may be a young type 2 diabetic patient or MODI and was being managed on the insulin because of the C-peptide, low C-peptide and young age. And this time when we see that Vina and metformin and empagliflozin has caused a marked change in the blood sugar levels, possibly he is not the type 1 and we should reassess again the C-peptide and if possible, we should go for the antibodies for the anti-GAD, anti-16.5 antibodies or for the MODI also. Because he has strong family history also.
Absolutely. I think that was again, I also thought in the same way. And let us see his recent, the last month's report. You will be really surprised to see this report. His pulse was 101. Blood pressure was absolutely normal. I mean, 106/71. His weight was 61.4. His BMI came down to 22. Blood sugar was 161 fasting. PP was 175. HbA1c was 7.2, which I think for last 20 years, he had never, I mean, the HbA1c was never less than 9 at that time. So his cholesterol was 214, triglyceride came down to 219, HDL rose to 63, enzymes, liver enzymes, absolutely normal. Creatinine was 1.2. I was also afraid of maybe he is going to some chronic kidney disease or diabetic kidney disease. So that's why his insulin levels are requirement of insulin was very low.
Mute yourself. Dr. Kameshwar, please mute yourself.
Hello.
Yes,
Can I
sir.
continue?
Start, sir. Please start. Yes.
Okay. So I'm surprised to see this report. His creatinine was normal. I was thinking in terms of that patient may be having DKD or something, a compromised kidney function. That's why insulin requirement was low. But he was feeling absolutely normal. Without insulin, he was feeling so good. No hypoglycemia. And his quality of life was so good. And he came to me in the June last month. And he was so happy to tell me that, Dr. Saab, you have stopped the insulin. His fundus, I thought that DKD is there. So fundus was done. Fundus was absolutely normal. I did the neuropathy profile. I had in my hospital, I have got all advanced machines for neuropathy profile. No neuropathy, no PAD was there. His cardiovascular system absolutely normal. We did ECG, we did echocardiography. We did every investigations last month to see whether any comorbid disease is there so that his sugars are perfectly controlled. But I found absolutely all systemic examination perfectly normal. He is still continuing Lina, metformin and EMPA. This is the scenario in front of you. And this is the real case of mine for last almost 23 years. Dear friends, Dr. Maheshwari, what do you think about that? Now, shall I show this is the real real investigations he has done from 2009 to 2013. And if you see here, you can see all the investigations, the CBC, hemoglobin, creatinine, liver enzymes, lipid profile, and glycosylated hemoglobin. You see all 20 years his glycosylated hemoglobin was 9 or above 9. Only in the June his HbA1c was 7.2 and he's perfectly all right. Dr. Maheshwari, what do you think? This is the whole 23 years sugars and this is the cholesterol only during this 10 years period, he has turmoil things. But recently, he is very much controlled. So, sir, Dr. Maheshwari, sir, what do you think? What can be a clinical diagnosis of this boy?
Clinical diagnosis is the diabetes, and the type of diabetes is to be discussed.
Okay,
It is to be
type 1,
discussed.
type of diabetes.
No, sir. No, I defer the diagnosis of type 1 because there's two great reasons. He is responding to the drugs which are not at all working on the insulinopenic patient, which I have already submitted to you.
Right.
Number one. Number two, it is our experience also that when we only go with the C-peptide level, that probably diagnosis may be misleading. You have to go, before identifying a patient of type 1, you have to have the anti-GAD antibodies to be done. Of course, sometimes if it is possible, get the anti-RSL antibody also. So that you are doubly sure that this is a sentence to the patient to take the insulin lifelong. So before giving a sentence to the patient for insulin taking insulin lifelong, you have to be doubly sure. So that was the mistake probably earlier done. And since because of your clinical experience, you have started all those drugs, and by the grace of the God, patient has responded. So everything is now being covered. But it is a carry-home message that every patient who is having an early onset diabetes and coming to you as a low C-peptide, please be ensured that you are dealing a patient with type 1 or something else, because the information is being available that the MODI is commonly seen in at least 1 to 3% of all diabetic patients can be MODI. So we have to evaluate the MODI. And in the type 3 MODI, we all know that the patients are having low C-peptide. So that may be a confusing state with the C, probably it is a type 1 or it is a MODI. So that can be only be ruled out by getting the GAD 65 done or anti-LHL antibody done.
Right. Any other comment from my co-panelist or anybody?
Very rightly, Sanjeev. And at the time when patient came with the low C-peptide, there may be so many factors. But at the time when he came and was started with the Lispro mix first time, he was having ketones 2+ and was having fever also.
Right.
So there was no problem, nothing wrong in starting insulin at that time for controlling sugar and the fever, as the patient was having some ketones also, which can develop many of the times in type 2 also. But later on, after that, he was continuing with the insulin and was not reassessed. That was something which we have to keep in our mind, so that proper evaluation and proper confirmation of type 1 should be done in all young patients before continuing for a very long time.
Perfect. So now
Can I intervene? Arvind sir?
Yes, sir.
I am not questioning the start of insulin. Any patient who is coming to you with ketosis has to be started with insulin. Why the metformin has been started? I am skeptical of starting the metformin in a patient having ketosis. Not at all. One should not start metformin in that patient. And why glimepiride has been started? That is also a point of the concern for that. Why glimepiride metformin is started in a patient who is having ketones?
Sir, it was started by family physician. And the glimepiride was given only for 1 month, and actually before he came to the specialist.
My message are, because there are certain things certain factors we are not discussing. Number one, had it been a type 2 diabetes, so why in the initial stage, why he had a polyuria, polydipsia, and polyphasia? Number one. My message is, in such a scenario, if type 2 diabetes is there, but he is associated some infective disease, like this patient had a K chest.
Yeah.
So in such a case, you can have a ketoacidosis. In such cases, you can have a presentation which could be like a mixed picture. You can have a type 2 patient can present as a type 1, because the symptoms are presenting which are never seen in type 2 diabetes. Number one.
Yeah.
Number two, in that scenario, insulin initiation was a must. No second question. Because in 2003, that was the best choice. Number three, we have never discussed the loss of the weight. Any person who is a BMI of 30, what in Asian Indians we call obese. It is not overweight, it is obese. And this fellow has come down from 30 to 21, which is absolutely normal BMI. This factor we are overlooking it. Loss of weight
Right.
from obesity to a normal weight, normal BMI, which is an Indian ethnicity, is 21, perfectly loses so glucotoxicity, perfectly because high TG lipotoxicity, and many riding factors, which is probably what Dr. Arvind says. He doesn't follow the commands of that diet. This
Right.
fellow has done a diet control. This fellow has
Absolutely.
done a lifestyle control. Had it
Absolutely.
been continuing on insulin, he would have gained weight. Had we continuing such a combination, he would have gained weight. But he's losing weight. The loss of the weight is
Right.
generally seen in type 1 diabetic. But the presentation at the end of the day, the insulin is stopped. That shows that he is a case of type 2 diabetes.
So,
I
so
perfectly
I
agree
just
with
want to continue with the another case, similar case. Just this is also a case.
Sir, one
Yeah.
thing,
Yes, sir.
I'll
Arvind, can you
discuss,
tell
sir.
me, सर एक पॉइंट रह गया ना तो सो हमें भी तो
Yeah.
बोलने दो
Sir,
भाई
sir,
मुझे
please.
बताइएगा what is a point against not starting pioglitazone any reasons
Sir,
Sir, 2 minute.
I
2
can
minute
say
दे देंगे,
that
sir.
pioglitazone is a good drug, but it definitely causes weight gain. There were days when we used to give up to 45 milligram of the pioglitazone, and all the patients at the end of 1 year used to get around 8 to 10 kgs of weight, and of course fluid retention.
you are
And
right
these are not the good things. And this weight is weight. They say that it's a very safe weight. It is
no.
not
The best-
visceral fat.
you are right
Fat is fat. So
Prakash
even
I
if
am convinced by
it is
you
not desirable. The
no, the
pioglitazone
point is this
already is coming for the last 10 years in a very good way with so many good effects. But
no,
have
I'm
to-
not saying recently now there have been a change in an approach of pioglitazone. It is not the 45 milligram, it is a 15 milligram, number one. Number two, the weight gain is pioglitazone is because of fluid salt retention, not the fat content.
Sir, it is
So
fat.
you have to
It
prioritize.
is fat. It is
Sir,
fat.
You
sir,
have to
not visceral,
prioritize.
but fat.
I tell you,
Subcutaneous
the
fat.
40
Sir,
feet.
Dr. Pradyumn Sharma, sir, just a minute. I want to
Even 15
interfere.
milligram
Uh,
causes weight gain.
Yeah, we will discuss this thing just
Yes.
2 minutes
ठीक है.
later.
Okay, done.
ये केस सर ये केस और देख लेते हैं.
Yes.
Sir, it
हाँ,
is a
ठीक है.
similar case, or almost similar case. 15-year-old boy again came with the recurrent boils for 2 months. Again had the similar osmotic symptoms. Also had the fever, maybe because of pyoderma or something. And he also has a weight loss. The almost similar case, but he was a 15-year-old boy with fasting sugar 256. PP was 453 and hemoglobin A1C was still very high. Again had ketones in the urine, but has family history of diabetes. Father was diabetes, his grandfather was diabetes. So this was the almost on the similar lines. And on examination, what we found, the BMI was still little higher side. Weight was 72, and he has got acanthosis nigricans and the skin tax also. We did the CRP, it was okay. Anti-GAD antibodies was done. It was more than 12. So GAD antibodies was higher or positive. And this patient was managed initially on insulin infusion because the ketoacidosis was there. And later on, he was converted into premix analogs around 12 and 6. And he was discharged. And he actually was continuing with the insulin and the later. He revisited after 15 days. His C-peptide was done after 15 days. This is a point to be noted, sir. 1.3 millimole, which was little on the normal side. Little different. Fasting sugar was 106. Postprandial was 165. We reduced the insulin. We started metformin, seeing his C-peptide. And next visit, we have to stop his insulin. And he was continuing with the metformin around 1000 milligrams. Dear friends, now we want to discuss these two case scenarios in front of you. And there is actually a scenario known as Flatbush diabetes. You must have come across this type of terminology. there are 4 forms depending upon the presence or absence of beta cell antibodies that Dr. Maheshwari and Dr. Tak has already been alluded to, that one should do the insulin antibodies or beta cell functional reserve by C-peptide. So we have to do all sorts of things to diagnose in this young diabetes. So there are 4 types. There can be A plus beta, A minus beta, A beta positive, and A plus beta positive. Means either there is a type 1, which is 100% autoimmune type 1 diabetes. Another is type 1, which is idiopathic, where we don't find any reasons or any causes for type 1 diabetes. Second is the type 2 diabetes. And the last one is the LADA, which actually, once we confirm that the patient is having latent autoimmune diabetes of the adult, then the diagnostic should be need 6 months survival without insulin. A patient should survive without insulin for 6 months. A patient can be a LADA. So this is known as APD. The only thing which every panelist, Dr. Prakash Keswani, everybody told that C-peptide at the time of glucotoxicity or new onset of diabetes should be confirmed later on within 1 to 3 weeks after settling of ketoacidosis. During ketoacidosis, the C-peptide is not the diagnostic one. So we have to, once the ketoacidosis settled, we have to repeat the C-peptide. That is one of the carry-home message today. I'll discuss, Dr. Prakash, I want to discuss 2 cases more, and then we will discuss Right. Can I discuss 2 cases very quickly?
And yes, sir, you said you can go, but quickly.
एक छोटा सा इसमें मैसेज ये है कि सी पेप्टाइड तो आप करते हो ठीक है, but C peptide insulin ratio is a more correct method. We should not absolutely rely on a C peptide. Always do, whenever there is a confusion, do a C peptide insulin ratio. Chances of fallacies are almost negligible. So the message should be, it's not only C peptide which is a riding factor.
Right.
It is a C peptide insulin ratio.
Right. I want to discuss just quickly 2 cases, and then we will discuss few very important points. This young girl, 18-year-old female, type 1 diabetes was diagnosed at 5 years of age. She was on insulin, total basal bolus regime, well controlled till last year, and the HbA1c was 7.2. Now she presented with recurrent UTI for 1 month. Fasting sugar was 180, postprandial was 282, HbA1c was little higher, 8.5, BMI was 26.5. On examination, blood pressure normal, skin tests were positive, all other systemic examination normal. Her C-peptide was very low. Now see here, 0.2. Cholesterol little on the higher side, 219, triglyceride 182, and LDL was high. So this was the case 2. Now, this seems to be a double diabetes, which you must have heard also this type of thing, that a patient can be of type 1 and type 2 diabetes. I have the panel discussion little later on. So I think thinking of a double diabetes in this case, a metformin was added. Now continued with another case, and we will discuss after this case. Again, 15-year-old female, these are all real case scenarios. Came with the UTI for 10 days, all osmotic symptoms were there. She was detected to have diabetes at the age of 13 years. When evaluating for urinary tract infection, basal bolus regime was given, fasting was 156, BP was 253, HbA1c was 9.2, urine ketones was absent. She had a strong family history, mother, maternal, grandmother, all were diabetic. On examination, she was lean, and BMI was 20 only, vitals normal, and systemic examination normal. Other lab investigations normal, chest X-ray, abdominal X-ray we did, especially it was not found anything. ECG shows sinus tachycardia, and biothiometry Doppler study. Normal C-peptide was here 101. So now the clinical diagnosis here, this was the P degree we did, and P degree we found all the maternal mother, grandmother, all were diabetic here in this case. So she had a strong family history. Dear friends, we want to discuss MODY here. Now this case was given actually, initially she was also given glimepiride and metformin. Now, what is MODY? I think let us discuss, and we will have a panelist here. We will discuss all these things. So monogenic diabetes should be kept in mind whenever we find these type of case scenarios. A monogenic form of diabetes associated with mutation in a single gene. Dr. Maheshwari has very clearly told just before that defect in the beta cell function, the diagnostic criteria is always if patient is less than 25 years, autosomal dominant transmission, that is very important. We have to see the family pedigree if it is possible. And if all the 3 generations involved, strong MODY should be suspected in any case. Absence of ketosis is one of the important findings if for the MODY, and these cases can be controlled without insulin, at least in the early stages of life, and then later on, and some cases respond to sulfonylurea, as Dr. Maheshwari told, it is MODY 3, and the clinical diagnosis again should be suspected if these criteria are fulfilled. Now we want to discuss from these case scenarios, sir. Dr. Maheshwari, sir. Hello.
Hello, Dr. Sanjiv.
Dr. Sanjiv, are you there?
Yes, am I audible?
Yes.
Everything has been very clearly told by you that the diabetes is not that simple. In earlier days, only 2 types of diabetes, NIDDM and IDDM. Thereafter, it has terminology has been changed, type 1 and type 2. Now they had type 3, 1.5 diabetes, and you have told the double diabetes, Flatbush diabetes. Everything is a probably what you call it as a nomenclature, but these nomenclature has some sense behind them. And these nomenclature to be very clearly understood by each one of us. Because I already told you, the management differs. Management differs, lifestyle of patient differs. Since it is a lifelong disease, so if we give a wrong management, probably it is caused great trouble to the patient and to the family. So diagnosis for each and every type of diabetes should be doubly assured before starting any management. To take care of acute emergency, you are free to do whatever you like. But thereafter, you have to manage your patient judiciously, scientifically, and logically. This is my wording.
Dr. Tak?
Yes, sir. I would just say that any person we are diagnosing diabetes under the age of 25 years, we should be investigating them in the detail to rule out whether it's a type 1 or autoimmune diabetes, whether it's a MODY or early onset type 2. We definitely are seeing much more common early onset type 2 diabetes. But because once we put the label, and usually that label sticks, so it's very important, particularly when the underage patient, under 25 or under 20, definitely we should be investigating the detail to rule out specific and label correctly.
Right. Now, usually these type of scenarios should also be considered that a patient is non-obese, a patient does not need insulin initially most of the time, and otherwise also some cases like HNF alpha, HNF alpha 4 alpha and HFF 1 alpha defects, that is MODY 1 and MODY 3. These patients initially are controlled on oral, and later on they also are insulin requiring diabetes. One important feature is MODY 2, which is again a very, very important thing, a isolated mild fasting hyperglycemia. Only the fasting hyperglycemia is there, and these MODY 2 can be controlled without treatment for a long period of time. So, I mean, there were different types of MODY should be there. Now, again a MODY 5, which is diabetes with renal cyst or renal agenesis. So we have to do the abdominal sonography in most of the cases in these young diabetics cases. And if we find the renal cyst and diabetes, I mean the agenesis sort of thing, we should think in terms of MODY 5 here. So there are different types of MODY. I don't want to involve, but Dr. Maheshwari and all other panelists and Dr. Prakash also told it is the MODY 3, I think, which is very, very important, and they are sometimes sulfonylurea responsive cases. Just quickly go to this case where actually I have borrowed this case from some my friend. 20-year-old diabetes, 2-year duration, recurrent abdominal pain. This is also scenario is there. And this patient was on OAD for 2 years, but still had the poor glycemic control. HbA1c was 9.1 in this case. This patient was lean diabetic. Blood pressure was okay. Systemic examination was normal. BMI was very low. It was 18. Lipid profile normal. Ketones were absent. Abdominal sonography in this case was found grade 1 fatty liver. So here, what we have to think over and above what we have learned just now. Dr. Pradyumn Sharma sir.
My understanding in such a case is already a low BMI. As a diabetic, we have to look for probably could it not be a type 1 diabetic, number one, because such a scenario. So the message is again coming back to this, what we have been talking as a C-peptide, number one, GAD antibodies, and probably we'll have to for C-peptide insulin ratio, because that is going to direct us. And that's the message. Such a patient normally have a almost lost great amount of beta cell, or probably do not have beta cells reserved. They are to be put on therapies like a insulin-based therapy. That's the message.
Right. Right.
So
now this was the abdominal X-ray, and it showed the large multiple pancreatic calculi. This is the case scenario, and this patient was managed by a 1800 calorie diet. This patient was put on insulin, premix insulin, pancreatic enzyme supplement was given, and perfect HbA1c control achieved within 3 months with this regime in this case. So this case is actually a fibrocalculous pancreatic diabetes. We should suspect in these lean type 1 diabetes. Whenever we are suspecting these young diabetes with a lean, we should actually go for these abdominal X-ray, very simple thing. And if we find these pancreatic calculi, these patients can be FCPD. This is very uncommon type. The diagnostic criteria is because we are living in the tropical country. Steatorrhea, the oily stools, one of the clinching point here, the steatorrhea, abnormal pancreatic function tests were there. So you either sonography or CT scan should be done in these cases. And absence of other causes of chronic pancreatitis like alcoholism, hepatobiliary disease should be ruled out in these type of cases. And if we ruled out, this can be a diagnosis of fibrocalculous pancreatic disease. So lean patients with history of oily stools, absence of ketosis, severe diabetes, plain X-ray abdomen is always indicated. So dear friends, there are several reasons for young diabetes. Like we have already seen the type 2 diabetes can be there, which is early onset. MODY can be there. Fibrocalculous pancreatic disease can be there. Of course, malnutrition modulated diabetes, we don't see too much in our areas. Diabetes secondary to endocrine disorders, I think Dr. Prakash will give some lights on this. And of course, some genetic syndromes are there associated. And in some young ladies, PCOD can be there for type 1 diabetes. I mean, the young type 2 diabetes. So differential diagnosis, the only first and foremost thing is the family history. If family history positive and it is present in 3 generations, then I think if ketonuria is no ketones are there, C-peptide is okay, then MODY should be suspected here. If family history is positive but not present in the 3 generations, Yeah, still ketones are not there. Early onset of type 2 diabetes should be predicted here. If family history is 100% negative and patient is still ketones positive, C-peptide absent, type 1 diabetes is one of the important diagnoses. If patient's family history is negative, no ketones, C-peptide is poor, abdominal X-ray should be done, and if possible, I mean, if pancreatic calculi is there, we should suspect this FCPD. So, yeah, so now I think we will discuss one by one. I mean, we'll take all the opinion of the house as well as our panelists that the diabetes in young is a real dilemma. Dr. Pareek sir, Dr. Girish Mathur sir, and Dr. Rakesh sir already told initially that it is a diagnostic challenge. It is not very uncommon these days. We find so many new young diabetes come to us, and we have to actually be very, very vigilant in diagnosis these young type 2 young diabetes cases. So if onset of diabetes, the ketones, the algorithm we have to think, the C-peptide should be done repeatedly after settling the ketoacidosis. GAD antibodies, GAS65 is available in our Jaipur and also in Rajasthan. I think there is no problem. We can go for GAD antibodies. The only thing is the MODY genes. MODY genes are done either at the, I think, Vellore, CMC Vellore, or at the Dr. Mohan Center in the Chennai. So they are doing free of cost to most of us. We send the samples to these two centers, and they actually oblige us by doing this sometimes free of cost. Challenges are definitely there, and I think if we can have the right diagnosis, the management can be much better. So now, Dr. Prakash, you can now have the summary of
really
this.
Today's evening was very fruitful, very learning, and has given positive things to all of us. It was really a mind-blowing, eye-opening meeting. The patients who comes to us, younger patients, we always do not have to think that he is type 1. We have to keep our eyes open. We have to rethink, and we have to there are two things. Patient has came in the emergency. We have to manage emergency. And the other thing is, at that time, we may be requiring insulin. But for making diagnosis, we have to keep our eyes open. And as you have already mentioned, and as the house has already discussed, Dr. Pradyumn Sharma, Dr. Sanjiv Maheshwari, and Dr. Tak, and yourself also, that we have to make proper diagnosis before labeling it forever. And many of the time, repeated investigation or these investigations, including C-peptide antibodies, helps a lot in making final diagnosis. Thank you, Dr. Arvind Gupta. This was a really nice meeting. And
but
I think,
Dr. Prakash, can have the house questions? Can
yes,
we take few questions from the house? Anybody can unmute and can ask or can write the questions also.
anyone from the house?
Arvind sir, one question, or rather one doubt from my side.
Right.
That why, despite of 20 years of very bad sugar control, patient did not develop the complications which are always expected to be there with him. Number one. And what was the reason of raised OTPT lying for so much amount of time? These are the two questions to be answered.
This is a dilemma. I presented this case. This is also one of the reasons for presenting this case. 20 years he was on insulin and raised OTPTs. Always, I was actually myself was actually surprised to see. I did all the last month. Actually, I did, and I told यदि तुम्हारे पास पैसे नहीं है तो मैं अपनी तरफ से सारा करा रहा हूँ. We did the fundus, we did the whole cardiology workup. मेरे ख्याल से कोई भी मैंने ऐसा टेस्ट नहीं किया उसको कि just to see कि कोई comorbidity तो नहीं हुई इसको 20 years. This is something which is unusual in this case. That's why, and all the cases are real cases जो मैंने आपको present किया sir today.
मेरा ये मैसेज ये है कि अपने first case में which we discussed and he had a K chest who lost almost 14 kg or probably more than that weight, हमने शुरू में उसका ultrasound नहीं कराया because the high TG levels and ultrasound fatty liver, you're expected to get OTPD somewhere around close even to 100, 110.
नहीं सर, उसकी सोनोग्राफी हुई थी सर, सोनोग्राफी हुई थी.
And it doesn't make a much of the sense. And you need not to do it. Let me finish. Then it doesn't require any further treatment because uric acid, whatever the reasons, is not that good drug. It's only controlling your lipid profile, coming your TG levels is the answer. That's the answer. And we, in that case, we did not go for an ultrasound tomograph. That's because it was a fatty liver. That's the reason. And now the second question from Dr. Sanjiv, complications. Many times it has been seen that the patient have probably susceptibility, even a very small history of 7-8 years, have many complications. Number one. Number two, the age was very young. He was at 22. That could be one of the factors. Had it been starting in the 2003, his age could be 42, then things could have been different. But he was a case of maturity onset diabetes with presenting as a septicemic presentation because of the fever. And that all mimic the presentation of type 1 diabetic. Once the things are settled down, once the infection is settled down, like in the second case, he had a multiple folliculitis, boys. So once the things are settled down, the infection settled down, things improve. That is the right time assessment. A proper assessment gives you the time, the answer, what is going to happen. So the point is a first investigation, a C-peptide may not stand to the same, number one. Number two, once a patient is settled down, number two is the answer. Number three, even a further correction, C-peptide insulin ratio stands a universal with the least error, giving the most diagnosis, even in patients who are insulin. It will tell you because the patient has a high C-peptide because of exogenous insulin or a low C-peptide because of lack of beta cell. Even with high exogenous insulin, you may have high C-peptide levels also. That is again one of the message. So it is an insulin which could be an exogenous, may even result in high levels. But if you do a fasting C-peptide and insulin ratio, things are better.
Thank you, sir.
Dr. Tak.
Yes,
Yes, sir.
exogenous insulin cannot cause increase of the C-peptide.
Yeah, exogenous insulin does not cause the raised C-peptide.
So the message is very much clear, Dr. Pradyumn Sharma, sir, that the patient after settling down, we have to reassess for the C-peptide.
Yes,
if it is desired, many of the times it is not desired, but many of the times if we redo it, and can help us in establishing the diagnosis.
Yeah.
So,
Dr.
Ramchandani,
you want to tell?
But again, we have to think for pioglitazone. It is a very promising molecule. Though in a different dose of 15 milligrams, is a very promising molecule. In a fatty liver disease, it is a #1 molecule which has a proven value in management of fatty liver disease.
Dr. Pradyumn Sharma, sir, just for the sake of that, we are dealing with the young diabetes and we are not sure about the diagnosis. It is type 1 or type 2 diabetes. So in this case, I think pioglitazone should not be, considered at this because we are not confirmed with the diagnosis. That is the point.
Say you have used even SGLT2 inhibitor on a one or two
SGLT2
study.
inhibitors ki trial ho chuki hai type 1 mein.
I perfectly agree, but it has not been universally accepted. It is a European Union has agreed use of SGLT2 inhibitor and type 1 diabetes. European Union.
Pio ka bhi kahin role nahi hai. Pio is not used.
That's what I'm telling you.
Pio is not recommended, not advised, not included in any of the guidelines, and it is not so good. Even after proactive trial and so many big meta-analysis, Pio is supposed to be good for the heart also, but there are still so many reservations for gaining weight. Fat is fat, whether it is the visceral or subcutaneous. Visceral may be more harmful, so Pio is not so safe, not so good, and even for the type 2, it should be used as a second or third or even the fourth drug of the choice.
Right. Dr. Ramchandani, your comment. Unmute karo, unmute.
Sir, I think first of all, I would like to congratulate you for this wonderful 4 different cases presentation and clarifying the how to approach in young diabetic. In day-to-day practice, we are seeing all types of cases, because the first case, the scenario in 2003, that time these drugs were not available or not very widely used, and we used to do C-peptide, because most of them in practical level, if you think, nobody is doing GAD antibodies still in small areas, because it's very expensive. Even C-peptide is also not doing. So first, we are looking the clinical diagnosis. Clinically, whether he is looking to the type 1, simple 5-6 things use. Just ask significant weight loss, urine ketones, history of vomiting and fever, or family history, 1 generation, 2 generation. And so
Sir, I think the time is over. That is why this is happening like this. So
Yeah.
you can say that our meeting has been very useful. Hello.
So by this stage, we can
Hello.
Diagnose. Actually, we should move. Yes, sir.
Yes. Very right, Dr. GD. These are good comments. So in the last, I think we have made a good discussion. All the panelists have made good questions and good discussion has been made. And in the last, I would like to thank all the panelists and Dr. Arvind Gupta sir for nice presentation, informative cases, interesting cases, and very different kind of the cases. So we have learned a lot for the young diabetics. Thank you very much, Dr. Arvind Gupta sir and all the panelists. And shall we close the session?
Yes, sir. Thank you.
Dr. Tak,
Yes,
Dr. Pradyumn Sharma, Dr. Arvind Gupta.
Yes, sir.
So we
Good.
can now close our session and
Thank
conclude
you.
this session with a message that we have to keep our eyes open. And this today's meeting has made us wiser for learning all these. Thank you very much, all the
Good night. Thank you.
participants.
Thank you.
Dr. Arvind Gupta sir, Dr. Pradyumn Sharma, Dr. Sandeep Tak, Dr. Maheshwari, Dr. G D Ramchandani.
Good night, sir.
Good night. Good night.
Good night.
Good night.
Our main Dr. K K Pareek sir, Dr. Girish Mathur sir, and Dr. Rajiv Sahai.
Yes.
All three were
All the three leaders.
pillars of this Rajasthan and national levels.
Yes.
Thanks to all them also.
Thank you.
And special thanks to Dr. Prakash Keswani.
Thank you, sir.
Special thanks to Prakash Keswani.
आपने आज बहुत ही बढ़िया काम